Okay, good afternoon and welcome to the September MDH Stroke Program monthly webinar on Transitions of Care models. I'm Kay Hirschfeld, the Transitions of Care Coordinator in the Stroke Program. We also have Angie Moschel from the Center Care St. Cloud Hospital here to talk about their post-discharge follow-up work under the Health Service Resources and Services Administration Grant, or the HRSA grant, that they received. Before we get started, we have a few housekeeping items to review regarding your participation in this webinar. So as usual, your lines have been muted upon entry. Please feel free to type questions in the chat box throughout the webinar. Instructions for how to access and utilize the chat feature are listed here on this slide. We'll save all questions until the end of the content. If we happen to run out of time, don't worry. We will address your questions in our follow-up email. Slides from the recording will be sent to you via email approximately 1 to 2 days after the webinar. So in terms of the agenda, we are going to start by talking about the American Stroke Association's policy statement recommendations for stroke systems of care, or the 2019 update. And while the policy statement itself covers the continuum of stroke systems of care, I'll be focusing on the post-acute side of the system. And within this policy statement are examples of transitional care models that other states have studied, so I'll be going over those studies and the results. And as mentioned, we'll hear from one of our very own Minnesota models, Center Care St. Cloud Hospital, on their post-discharge follow-up work. So first I'll start by giving you a little historical perspective on the American Stroke Association's policy recommendations, or abbreviation ASA. Back in 2005, the AHA and the American Stroke Association first issued policy recommendations for the establishment of stroke systems of care. And in 2013, they expanded on those recommendations by providing a statement on interactions within stroke systems of care, which supports certification of stroke systems of care. And this is to improve measures to improve patient care and stroke outcomes. This would be your designation for acute stroke-ready hospitals, primary stroke centers, certified stroke centers. And the aim of this policy statement, which is our focus today, is they evaluated those stroke systems of care, and it's based on the improvement of what they've seen to date in stroke care. And what they found is while we've made great improvements in EMS and inpatient care, there's still a need for improvements in the post-acute side of the system. Studies have shown that after hospitalization, 25% of stroke patients are readmitted within 90 days, over 25% are not medication compliant, over 50% do not have their blood pressure under control, and patients are sedentary greater than 78% of the time, as well as 73% of patients fall. Also, over 50% of stroke transient ischemic attack, or TIAs, are discharged directly home without any follow-up care. So some of the barriers that prevent follow-up care is, some of the barriers that we've seen with post-acute is lack of structure in the stroke pathways, especially as it relates to screening for stroke complications. This would be your falls, hypotension, hypertension, recurrent stroke, TIA, cardiac complications, dehydration, and renal failure. And unfortunately, there are no U.S. hospital measures for the quality of post-acute care at this time, like there is for inpatient care. And another barrier is access to insurance, such as medications to prevent stroke. And then access to post-acute services like home health facilities, especially in greater Minnesota. Lack of stroke education is another barrier. And although that's a quality measure and reported at discharge, at time of discharge, it's more important to do post-stroke follow-up and stroke education after discharge, because patients are receiving so much information at the time of discharge that they may not retain it all. So not only do we need to be looking at possible symptoms for reoccurrence of stroke, but also stroke risk factors, medication appointments, primary care specialists and therapy, and then also lifestyle changes. So in the past, most of the focus to reduce readmissions has been on hospital-related factors. You're probably familiar with the Centers for Medicare and Medicaid Services mandated all 30-day readmission penalties that they started in 2016. And while hospital factors may play a role, they're finding more that we need to be focusing more on the social, functional, and community determinants of health, which are more important in later admissions, especially those 7 days after discharge, in order to reduce mortality, maximize recovery, and prevent recurrent stroke and cardiovascular health events. So now I'm going to talk about some of the transitional care models that were mentioned in the American Stroke Association policy statement that focused on some of these social, functional, and community determinants of health. First is this transitional stroke clinic model led by a stroke nurse practitioner and registered nurse. The primary aim of this study was to reduce 30-day and 90-day readmission for stroke and TI patients. The study time period was 3 years. The location of the study was at Wake Forest Baptist Medical Center in North Carolina, which is a comprehensive stroke center. 510 patients participated in this study, and they had 2 phases to this study. The first phase, they had a nurse practitioner calling only high-risk patients, discharged home within 7 days, and performing an office visit within 2 to 4 weeks of discharge. And then what they learned through these phases is that an RN could be making those calls, which freed up time for the nurse practitioner to work in the stroke clinic. So then during phase 2, all patients discharged home received both a 2-day follow-up phone call by an RN and a follow-up visit with a nurse practitioner within 7 to 14 days. So not only were they able to have an RN do the follow-up calls, which freed up the time for the nurse practitioner in stroke clinic, but also they shortened the time from when patients were followed up from discharge and also from when they were seen in the transitional stroke clinic. So primary outcomes of this analysis were 30 to 90-day readmissions, which were collected by telephone interview, medical record review, mail questionnaire, and then also looking at post-stroke complications and medication adherence. So from phase 1 to phase 2, they found that the follow-up calls increased from 55.7 to 88.9%, and that they also, the days from discharge to transitional stroke clinic decreased. And then patients who received the follow-up phone call were more likely to show for the transitional stroke clinic than those who were not. And then they also saw that the transitional clinic visit was associated with a 48% reduction in 30-day readmissions. So from this model, the transitional stroke clinic model that I just discussed, they moved it to a pragmatic clinical trial, which was implemented across the state of North Carolina, called a Comprehensive Post-Acute Stroke Services Model, or COMPASS model. And the study was funded by Patient-Centered Outcomes Research Institute, or PCORI Research. And the aims or outcomes of this study were to test functional status or physical health 3 months after leaving a hospital. Secondary outcomes were to reduce caregiver strain, all-cause 30 and 90-day readmission, mortality, healthcare utilization like emergency room, hospitals, skilled nursing facilities, up to 1 year post-stroke hospitalization, and then medication non-adherence. This was a 5-year study plus a randomized clinical trial, and the location was North Carolina Stroke Belt, which in the eastern area of North Carolina, 20 to 40% of residents are more likely to die of stroke than other parts of the country. 40 hospitals participated in this study, and they were both urban and rural hospitals, and they had 6,024 stroke and TI patients enrolled in the study. And the methods that they used is they had a post-acute coordinator visit prior to discharge. They had 2-day phone calls that were made to patients following discharge, and that was to see and make sure that patients had what they needed. They did a 14-day in-person post-acute stroke clinic follow-up visit to make sure that there were no problems, or if the patients were having problems, trying to resolve those issues, and then they developed an individualized care plan at that point in care. They also connected them to rehab community services, which is an important or unique facet of this model, because each hospital that participated in the study had a community resource network, which would map the patient location to the services that were available in that area. And then they also used a trained community coordinator to work with those local organizations and check in on them. 30 to 60-day phone calls were made to assess functional status and to also make sure that patient was utilizing the recommended services. And they learned about the status of the patient through the 90-day telephone survey. Now, this study also had 2 phases. Half the patients in phase 1 were the COMPASS model, and then half were the usual care. And then in the second phase of this study, they took the usual care hospitals and moved them into the COMPASS model, and then they also, the phase 1 hospitals, continued to provide comprehensive post-care services. Now, the results of that study, like any study, they can be challenges, and one of the challenges they experienced was it was not easily incorporated into the system of care. There were staffing issues. Only 35% of the patients received the intervention due to hospital delivery of care interruptions and also patient compliance. Some of the patients went to primary care instead of following up with the hospital stroke clinic. But they did see an improvement in home blood pressure monitoring, self-reported by 72% of those in the intervention patients versus 64% in the usual care model. Secondary inclusions, where they've seen clinically meaningful improvements in functional status, satisfaction with care, mortality, falls, disability, depression. And then the next step that they plan to do is to develop a telemedicine model. Early supported discharge is another model of transitional care in which patients are discharged home early and receive rehabilitation and specialized stroke services from a hospital-based multidisciplinary team that includes physical and occupational therapists, nurses, social workers, stroke neurologists, and a personal aide. Now, patients that benefit from this kind of model are those that are elderly with moderate disabilities. An important premise of this study, again, is the community services, hooking up these patients with exercise programs, falls prevention programs, caregiver support groups, nutrition and transportation services, and of course, warm handoffs to primary care. Now, this is a standard of care for Canada and the United Kingdom, but has yet to be evaluated in the U.S. or non-urban settings. Results are, what they find with this type of model is that they can decrease the length of stay equivalent to 7 days. They can anticipate, prevent, and manage stroke complications. It's shown improved functional status, optimized stroke risk factor management, and reduced caregiver burden. And so now these are just some of the TOC models mentioned in the American Stroke Association policy statement. I can't do all the models in the interest of time. And we also wanted to hear from one of our very own Minnesota models on their post-discharge follow-up work. And although there are other hospitals in Minnesota that do post-discharge follow-up on stroke patients, we chose to highlight CentraCare St. Cloud's hospital model today because it involves a grant study on the use of telehealth, which is becoming more important for following up on patients, especially during this COVID pandemic. And their model also partners with regional sites and acute stroke-ready hospitals on this follow-up. So now I'm going to turn the presenter role over to Angie Mosho, and she'll tell you about their grant project work. Many of you already may know Angie, but if you don't, she'll begin by providing a brief introduction of herself.
All right. And can everybody hear me okay? Wrong direction. All right. So with that, yes, my name is Angie Mushel, and I'm our registered nurse with the St. Cloud Hospital Stroke Center. I have been with the St. Cloud Hospital for 20 years. I have been within the Stroke Center for 3 years. And I also have Sarah Bastro on here as well, as she was our telehealth stroke coordinator early on with the first initial grant. She unfortunately is not able to join us today. She has been a registered nurse with CentraCare Long Prairie Hospital for the last 5 years, initially starting out with the HRSA grant as the patient navigator, and has since been added on other additional roles, such as the stroke coordinator for Long Prairie, along with continued direct patient care roles. So this is just a real brief overview of who we are, who CentraCare Caris Health is. we have 8 hospitals within our systems, close to 13,000 employees, and 30 different clinics. So just kind of a real brief overview of our location and who we are. On this next slide here, this breaks down the Center Care Telestroke location. So the red star represents St. Cloud Hospital, and the green circles represent the 20 different telestroke sites that we have within our system. You will see on the list, if you actually count, there is 21, as we have included the St. Cloud Hospital as we have implemented telestroke within our own ER within the last few years. So the first thing that I just want to kind of talk about today is, so we're going to talk about the transitions of care for our stroke patients. Back in October of 2015, we had received our first initial grant from the U.S. Department of Health and Human Services Rural Health Care Service. So this grant would allow better access for patients to access their care and hopefully to help improve the outcomes for our patients after they were recovering from a stroke or a TIA. So during the first 3 years of this grant, we were able to bring up eight sites, and they are listed here on the slide: Glenwood, Long Prairie, Melrose, Painesville, Fox Center, Staples, and Wadena. And I forgot Benson was in there as well. And we had a couple goals with this project, and that was to be able to improve the quality of life scores, along with the hopefully to see a decrease in the degree of disability. And then the last goal obviously was to obviously increase that patient satisfaction and have those patients not have to travel back to St. Cloud, because as I get further along, you can see we have some sites that are quite a ways away and not having to drive in some of those torturous winter conditions. So with that first grant, we were able to enroll 132 patients. And with this grant, what happened, like I said, Sarah Zastra was the patient coordinator. She would contact these patients, and she would enroll them into the grant and ensure that they had a follow-up appointment scheduled. So she was able to enroll 132 patients into this program. And what we did was we looked at the modified Rankin score at enrollment, and then again at 6 months to see if we compare our results. And it did show that we had a 53% decrease in that degree of disability among the enrolled patients. 77% of those patients did complete their follow-up with the stroke neurology. And of that 77% of patients, 95% of them who had the telehealth follow-up appointment would not choose to drive farther for that face-to-face appointment. And then we did also look at our all-cause admission rate as well, and that for those patients that were in this program, the readmission rate was less than 9%, which is below the national standard of about 12% for all-cause readmission rate. And of course, after the 3 years, we had to look at the sustainability, because then that would mean Sarah was done with that piece of it, and how was this going to look. So what happened after that was I took on those follow-up phone calls for those patients. Sarah was calling these patients at 7, 30, 60, and 90 days. Currently, St. Cloud Hospital is just calling at the time of this grant was just calling at 7 and 90 days. So the sustainability piece of it, those phone calls actually came back to me, that I would take on those phone calls to those patients that were discharged from St. Cloud Hospital from those sites. They transferred from those sites and discharged from St. Cloud. And then the scheduling piece of it, we did turn that over to the Center Care Stroke and Vascular Clinic for them to schedule that appointment. There's a little bit of behind the work that needs to take place. So what happens is we have instructed our providers that if they see a patient that comes from one of those facilities on the discharge order, to enter in telehealth follow-up appointment in Long Prairie. That cues our HUCS unit secretaries to send that order over to the Stroke and Vascular Clinic, and then the Stroke and Vascular Clinic takes that order. They schedule that a patient, because they need to make sure that, like I use Long Prairie, for example, they need to make sure Long Prairie has a nurse available on the day of that appointment, and we need to schedule that telehealth cart to make sure that that is available as well. And then they reach out to that patient within a couple of days for that appointment. So I guess the only downfall would be that when the patient leaves the hospital, they don't know the date of their follow-up appointment with a stroke. provider because of, like I said, the behind the scenes work that happens. So in June of 2019, we qualified again for a second grant to bring up another 8 sites to be able to offer post-stroke services. Sites that were identified in this second grant were Aiken, Alexandria, Appleton, Little Falls, Madison, Monticello, Olivia, and Wilmer. So all sites except for Little Falls are up and running as we speak. Little Falls should be up and running hopefully by the end of October, November. Unfortunately, COVID put us a little behind on getting them up. So we are back onto our road for recovery, so we should have them up real shortly here as well. So currently for this program, we have 76 patients currently enrolled. And again, we're using the same information that we had from the first grant for our goals and looking at that, looking at with the degree of disability. So as of today, 95% of the patients enrolled either have improved or they have no change to their disability. 78% of patients upon initially enrolled had no disability assessed. And as of now, that all-cause readmission rate is at 6.5%, so even lower than what we were at with that first grant. And of course, the sustainability piece of it again will be those calls coming back to myself. However, we are now doing 30-day calls, so that has been since added, and that's what I'm going to move into next is the St. Cloud Hospital 30-day follow-up calls. So like I previously mentioned, St. Cloud Hospital was doing 7-day follow-up calls to our stroke patients that discharged home, and then we provided 90-day phone calls to those stroke patients who received IV alteplase and or had a thrombectomy. So in July of 2008, I started doing the 30-day follow-up phone calls to those patients who were discharged home. So and kind of how that works, what that process is I receive a weekly confirmed stroke report from our data abstractors. I take that report and I run another report out of Get With The Guidelines, and it's the PMT report, and I compare those lists. And on that list that I get from our data abstractors, it does indicate where the patient discharged. We have codes, and it does discharge or indicates if they discharged home or home with home care services. So then those reports, the PMT report from the Get With The Guidelines is exported into an Excel spreadsheet, and then like I said, that's how it's compared, and that's how I keep track then of those patients that need to be called. And each patient does get a phone call twice, and that was something that we have done with the 7 days and the 90 days, and we've just continued to keep that process of calling those patients twice, and we have a defined time frame. So with the grant that we were doing with the 30-day calls, we defined that we would call them no sooner than 5 days before that 30-day mark was up and no later than 5 days after. So we have a 25 to 35-day window. However, most of these patients are called right at that 30 to 31 day of discharge. And the questions that are asked are on the side of the screen. So these are within the Get With The Guidelines. And from the Paul Coverdale grant. So we ask them about we do a modified Rankin scale. We ask them about if they were referred to any outpatient services. And if they were, I ask them why they didn't continue with those services, asking them if they've had a follow-up appointment, making sure that they are taking all of their prescribed medications. Sometimes we know patients like to stop on their own. If they've had any ED visits or any hospital readmissions, if they were identified as a tobacco user, I do ask if they are still continuing to use tobacco, and if not, just kind of a real brief conversation of, their reason for not wanting to quit or not quitting. Ask them about monitoring their blood pressure, and then the last set of questions that I ask is the PHQ-9 depression screening questions. And of course, with everything, there is always challenges and successes that come with these change in processes. So the challenges that I came across with doing these 30-day calls is not anything new or different that I've experienced with the 7 or the 90-day, and the biggest one is obviously reaching the patient. Sometimes with these 30-day calls and that middle-aged population, like the 40 to 50, 60 age range, especially if they're still working by 30 days, some of these patients are back to work, which is a good thing. So that's been a challenge, is reaching the patient. I did try calling different times of the day to see if that would make a difference, and I really found that it didn't really make a difference in reaching those patients. And then probably one of the biggest challenges and frustrations is when we're running the reports from the Get With the Guidelines. The number of patients that I have on my Excel spreadsheet don't match up to the number of patients on the bar graphs that come out of that report. So Melissa Freeze, the program coordinator here at St. Cloud, she is working on that, digging into that a little bit more to try to understand how we can capture all these patients so that we can do something with this data and that it's meaningful and that we know that we're capturing all of those patients that were called. And then, of course, successes. The big thing I hear is patients appreciate those follow-up phone calls. They always say, thank you for checking in. And even at 90 days, they're still actually kind of surprised that we're still thinking about them, is what I have heard, and that we're interested to see how they're doing 3 months out. So that's the big thing that I hear from them. In the early days of the pandemic, early April, May, I was able to reach more patients just because more patients were home. They weren't doing much of anything. The downfall to that was because they were home, some of these people really did like to chit-chat because I think they were just happy to have somebody else to talk to other than maybe their significant other at home. And then also I am working from home and using my cell phone, I'm actually getting patients to return phone calls back. I typically don't leave a voice message if I'm not able to reach these patients, but patients will see a cell phone number and they do return that phone call back. So I've been able to actually get a hold of a lot more patients since the whole start of this pandemic of COVID. And overall, though, I think the success of the phone calls are going well. So this last slide here just shows our data for this last fiscal year. So this is our fiscal 2020 data, so July 1 of 2019 to June 30th of 2020. And you can see the different quarters, and I've got the numbers below. You can see the total number of calls, how many patients were reached on that first attempt, and then how many patients were reached on the second attempt, and how many were unable to be reached. And then there is two columns to I'm looking at my right. We have a missed opportunities and no phone calls made. So the missed opportunities, the biggest reason there is patients would not show up on the confirmed stroke list within that time frame, and they would show up after that defined time frame that we identified of calling those patients. So those were the missed opportunities. And the biggest reasons for no phone calls made would be that I've run into is either the language barrier. I've had a couple patients that have been readmitted, or they were readmitted and then they ended up going to a skilled nursing facility after that second readmission, so then we did not make a phone call. Or if there's no phone number been listed in the chart. So that's been the biggest reasons for no phone call made. So that is kind of our 30-day follow-up transitions of care calls that I do here at St. Cloud. So with that, I will turn it back over to Kay.
All right, thank you, Angie. We are glad to hear that your grant work has been a success. Now we'll just take a little time for some questions and before we close up this session. So are there any questions? I don't see any in the chat box. If you have questions, please enter questions in the chat box or unmute your line by pressing 6. All right, we're hearing none. I hope you found this webinar helpful and are leaving with a better understanding of the types of transitions of care models being used for stroke follow-up and how they can improve patient outcomes. We encourage you to develop your own post-discharge follow-up processes in your own hospital based on some of the successes and lessons learned from some of the models that we discussed here today. Now we ask you to please complete the webinar evaluation. That evaluation helps us identify future webinar topics. And if you have other transition of care related topics you'd like us to cover and or other stroke topics in general, please let us know. We're always interested in receiving your feedback. Additionally, 0.5 contact hours are available for attending the webinar. If you'd like to access those contact hours, you'll need to complete the evaluation. A link to the evaluation has been placed in the chat box. Click on the chat bubble and the chat box will appear with a direct link. No worries if you can't get the chat box to appear. Our team will send you out a follow-up email later today, which includes the evaluation link, today's slide deck, and a follow-up on any questions. And then once the recording is available on the stroke program's YouTube playlist, we'll send out another email with a link to the recording. So this concludes today's webinar. Our next webinar is scheduled for October 21st, 2020. It's on modified Rankin. Stay tuned to a calendar invitation approximately 2 weeks before the date. And thanks again for your participation. Enjoy the rest of the day. Stay safe and healthy.